This is Dr. Hakan Paydak. I'm from University of Arkansas for Medical Sciences in Little Rock, and today I'm at the International Academy of Cardiology Annual Scientific Sessions in 2016, 21st World Congress on Heart Disease, and I'll be presenting a study that we had presented at the Heart Rhythm Society meeting in 2012 and published in Europace in 2013. The title of my talk is P-Wave, Innovative P-Wave Discrimination Algorithm for Discrimination of Supraventricular versus Ventricular Tachycardia in Patients with Single-Chamber Dual-Coil Defibrillators. The idea of using CAN2 supraventricular spare vena cava coil vector imitates or is a surrogate in the EKG of Eindhoven lead 1 electrocardiogram. Hence, in patients with single chamber dual coil defibrillators, we can get extra information and see the P waves very nicely because the spare vena cava is just next to the right atrium. And we can use this information in discriminating supraventricular versus ventricular tachycardia in patients with defibrillators. Dual chamber defibrillators have been advocated in favor of single chamber defibrillators in prospective randomized trial done by Dr. Friedman several years ago and was found to be better in a prospective randomized trial to discriminate. However, single-chamber defibrillators have been advocated, especially by the Center for Medicare and Medicaid, because single-chamber defibrillators have been shown to be beneficial in preventing sudden cardiac death in studies such as sudden cardiac death in heart failure trial. In addition, adding an atrial lead may cause increased complications and also in hospital 1-month mortality that was shown in a study that was published in JACC. So the idea of utilizing CAN to spare vena cava vector or configuration in single chamber ICDs came to us because we could delineate the P waves very nicely. And at the University of Arkansas for Medical Sciences, we performed the IRB-approved study in 140 patients who had single-chamber dual-coil Medtronic defibrillators. Unfortunately, we cannot use this configuration for storing electrograms in other device companies' defibrillators such as St. Jude Medical or Boston Scientific Devices. When we looked at 140 patients, 61 of them had eligible electrograms for us to look into, and 27 of these patients had either one or more episodes of ventricular tachycardia or supraventricular tachycardia or both. When we looked at the electrograms, we found out that the P waves were much bigger in CAN2 SVC configuration. R waves were much smaller in CAN2 SVC configuration, but most importantly, the ratio of P waves to QRS complexes was 14-fold higher in CAN2 SVC configuration as compared to the out-of-the-box CAN2 right ventricular coil or HVB high voltage site B configuration. So this we thought would be helpful in discriminating, in diagnosing ventricular tachycardia. In our study population, 21 patients had ventricular tachycardia, and as we all know, atrioventricular discrimination, atrioventricular dysynchrony is the hallmark of diagnosing ventricular tachycardia and is 100% specific for diagnosis of ventricular tachycardia. In our study population, 13 of the 21 patients had atrioventricular dissociation by the CAN to SVC configuration as compared to only 13 of the 21 patients had AV dysynchrony as opposed to only 3 of the 21 patients who had in the CAN to HVB or CAN to RV coil configuration. So there was a 15-fold better chance of diagnosis. The odds ratio was 15 for diagnosing ventricular tachycardia by utilizing this CAN to SVC configuration. On the other hand, in patients with supraventricular tachycardia, this was also very helpful. In 13 patients, we diagnosed supraventricular tachycardia, and this configuration was helpful. The Canto SVC configuration was very helpful in 12 out of the 13 patients, or in 92% of the patients, as compared to only 3 out of the 13 patients in whom we used Canto right ventricular coil configuration. So we found that there was a 50-fold advantage of using this Canto superior vena cava configuration in diagnosing supraventricular tachycardia correctly. So in conclusion, this configuration is not programmed out of the box for Medtronic single-chamber dual coil devices, but you have to program it. And in all of our patients with single-chamber dual coil Medtronic defibrillators, we do this automatically, and this is very helpful in follow-up to patients. And when they have an episode of arrhythmia requiring anti-tachycardia pacing or shock therapy, we can diagnose ventricular tachycardia by seeing the atrioventricular dysynchrony, and supraventricular tachycardia by delineating the P waves accurately because of the proximity of the superior vena cava to the right atrium. This study, I hope, will help the Medtronic company to incorporate this algorithm into their SVT versus VT discrimination algorithm and prevent inappropriate defibrillator shocks, because inappropriate defibrillator shocks can increase morbidity and mortality in patients.